I thought to fit in with the other speakers, what I could talk about were a couple of studies that we've been doing which throw light on the difficulty of diagnosis and also the causes of more severe disease in older adults compared to younger adults. So this is a review that we published just a few years ago about the spectrum of RSV disease, which is really emphasizing I don't know if I can get I'm not sure if I can get a pointer up. No, I don't speak Italian, so I can't. Emphasizing that although we're very familiar with RSV as a disease of children, it certainly is a very important cause of serious disease in older adults and often underdiagnosed. And I think Anne Falsey and others in Rochester, New York, were really in the vanguard of demonstrating just what an important infection RSV could be, but that it's often hidden. And we know that the immune responses to viruses change during the life course, and that there are very special things about the immune responses in infancy which differ from those in adulthood. So we've been studying those changes over time. We've also been looking at the difficulty of diagnosis, and this was a study which was supported by Rescue. We had a clinical research fellow who was looking at the difficulty of diagnosis in older adults, particularly with COPD. We know that in primary care in particular, there's really little incentive to test for RSV because there are no specific treatments. And indeed, even in our pediatric wards, the pediatricians stopped testing some years ago because of trying to reduce the cost of hospital admission and the fact that making a specific diagnosis didn't actually affect their treatment. And of course, the costs of doing PCR analysis are quite considerable. So in this study, you can see from the American Journal of Emergency Medicine, they showed that only 36% of admitted patients were ultimately diagnosed, who were ultimately diagnosed with RSV, actually were initially swabbed on admission. So really quite low diagnostic testing. Now, this was the study that Dexter Wiseman did during his PhD, working jointly between myself and Visha Venjiha at the Royal Brompton. So Dexter set out to compare serology with PCR in a very intensively studied cohort of patients with chronic obstructive pulmonary disease. So there were over 300 people enrolled, both in London and also in Groningen in the Netherlands. And there were approximately 1,000 clinic visits documented during this time and looking for causes of exacerbation. And when we looked at the sequential serology data that we had using some very sensitive serological assays that performed on a regular basis through the course of the study, we were able to identify 20 episodes where there was a rise in serology to RSV, almost certainly, we think, indicating an RSV infection. But only 11 of the exacerbations were positive for RSV by PCR testing. And that was despite having clinic nurses and domiciliary nurses going out to take samples and having a dedicated phone line straight to Dexter for anyone who suffered an exacerbation. So in fact, there were only 4 overlaps in this study between the PCR diagnostic and the serological diagnostic. And I think you could say that intensive investment in sequential serological testing might actually be a more productive way to find out whether people have had RSV than doing all that PCR testing. Now, this is a slide which might help you in response to one of those questions. So this is looking at the post-hospital survival over a 12-month period after admission for either influenza or RSV. And you can see that the actual survival rate of people who have been admitted with RSV in older adulthood, so this was a mean age of nearly 80, the one-year survival rate was lower for those admitted with RSV than for those admitted with influenza. So it can be a very significant disease, not only acutely, but also over the subsequent year. So the question that these studies of adult RSVs has really triggered in us is, what is the difference in terms of the immune responses? So this is a summary from our annual review of immunology, which we wrote a few years ago, summarizing all that we know about the inflammatory disease which is caused by RSV infection. And you can see that there are a range of different types of disease which are caused. I think something which has very much worried the immunologists has been the inflammatory response, which is sometimes augmented by vaccination, both in the studies that were done with formalin inactivated RSV back in the 1960s, but also a lot of laboratory studies done in animal models. Fortunately, I think we've now come to understand how that augmentation occurred, and understanding augmented disease and understanding how to circumvent it, particularly with the pre-fusion form of RSV, which is now incorporated into the vaccines, has allowed the breakthrough now of finally launching vaccines onto the market. So we've been doing experimental infections with RSV in volunteers, and we started with just ordinary adult volunteers who were low risk of severe disease. And we started doing this, I guess, it was just before the flu pandemic, so it was 2008 that Max Habibi, who's pictured on this slide, started infecting our volunteers. We had done some rather haphazard RSV infections on lab volunteers back in the 1990s, but that was in the era before it was tightly regulated, and we just took some RSV out of the freezer and infected various postdocs. But this was a much more regulated attempt to try to do something systematic by way of human challenge. So at that time, we were able to get hold of this Memphis 37 virus, which was originally grown from a patient being looked after by John DeVincenzo, and which had been grown up under very strict conditions. And we started doing this using student accommodation, but then ultimately moved into an experimental facility where it's much more highly regulated. So those initial adult studies surprised us in that we were getting quite a lot of inflammation in the airway, which was asymptomatic at day 28, but very much evident on bronchoscopy. And you can see on the right, day 28, there's quite an abnormal appearance of the mucosa, although our volunteers have gone back to normal. And more recently, we've been doing this study called Inflammage. It's not Inflammage, because that's confusing for the French. So this is Inflammage. And this is supported by the Medical Research Council, but a collaborative award that we hold together with GSK. It's a big collaborative between 5 different UK universities. And basically, we set out to enroll older adults now, trying to get it to a more realistic situation where we were studying those at higher risk. And we were again using the same Memphis 37 strain, and we were able to monitor very intensively what happened after inoculation. So if we look at these older adults, we initially looked at a cohort of over 500 participants who were eligible, we thought, possibly to be included in the study. And we narrowed it down after intensive screening to 22 individuals who we thought were still at low risk, but were aged between 61 and 73. So, risk because of age, but not because of other risk factors. And we could then infect them with the same virus, and we found that actually the infection rate, if anything, looked rather higher in the older adults. And they did also have higher viral loads, and they had an increase in symptoms. In the younger volunteers, we found that pre-existing serum antibody is poorly predictive of resistance to infection, whereas nasal antibody was more highly predictive. But then when we look at the older adults, this is actually some rather preliminary data. We have got more data than this now, but it shows the same thing. In older adults, the serum antibody is more predictive than it would be in younger adults. And I think that's interesting because it fits with a prediction that Anne Falsey made, which is that boosting serum antibody in older adults might actually, with vaccination, might actually be highly protective, whereas perhaps in younger adults the same might not necessarily apply. The other thing we found in this InflamAge study was that there seemed to be a relative deficit in the local IgA response in the nasal mucosa to the pre-F form of the RSV surface antigen. So they are not very good at responding in terms of mucosal responses. So why do we think older adults are so much more vulnerable? I think there may be quite a number of factors to do with the way in which older adults respond immunologically. But I thought this is a very interesting study. This is actually not on RSV at all, but this was a study that was published in Science looking at immunosenescence and emphasizing that in older adults there is an increase in the baseline levels of inflammation in the mucosal surface, and that during viral infection, in this case with a beta coronavirus, that baseline is built on by the infection, so raising the inflammation to a higher level. And because you're starting at a higher level to begin with, then that augmentation of inflammation in older mucosa is important. So these are huge collaborative studies, and I can't possibly acknowledge everyone who's involved, but this is really to acknowledge the team that in particular did those challenge studies, and I think team science and collaborative science is absolutely the way forward. So thank you very much.